significant geographic and center-to-center variability around which specialist, a pulmonologist or a cardiologist, would be more likely to make an initial diagnosis of pulmonary arterial hypertension. In different centers, PAH is seen by cardiologists, whereas in other centers, PAH is primarily seen by specialists in pulmonary medicine. Some centers also have a mixed approach, with both pulmonologists and cardiologists seeing patients with pulmonary arterial hypertension and making that initial diagnosis. The initial diagnosis tends to be made mostly by providers who have expertise in pulmonary hypertension and are either cardiology or pulmonary trained. Rheumatologists play an important role in screening for pulmonary arterial hypertension in patients with high-risk conditions such as scleroderma, and will often first detect signs or symptoms of pulmonary hypertension, but then refer their patients with connective tissue disease-associated pulmonary arterial hypertension to specialists for right heart catheterization, definitive diagnosis, and treatment by a provider with expertise in pulmonary hypertension.
Well, there are a number of specialists who treat PAH and PH: cardiologists, rheumatologists, pulmonologists. Certainly, we're seeing intensivists inside the hospital, other physicians who have particular specialties. I think the real question is, who is the best clinician and maybe the best care team to treat a given clinical situation in a patient? And that's ultimately going to be the responsibility of the health system, of the provider organization. Certainly, one of the rate-limiting steps in terms of access to specialty care is the fact that at last count, there are only 52 PAH-approved centers in the United States. And when you talk about patients who live in underserved areas, especially rural areas, access to that is going to be very problematic. One of the things that we've done traditionally is not require that there be a specific specialist that orders a drug, because in many scenarios, and PAH is certainly one of them, patients may go to the academic or tertiary care center, get their treatment plan developed by the specialist, and then return to their community where the day-to-day management is done by an internist or even a family physician. Ultimately, what we're really talking about here is how do we maximize care coordination between the specialists, between the other healthcare professionals, which may not necessarily include physicians, but also PAs, nurse practitioners, and how we make sure that for patients, regardless of where they live, whether it's in an urban area, an underserved area, or wherever, that they're still going to have the optimal access to care. That continues to be obviously one of the major challenges we have in the United States, and care coordination is really a part of that solution. The referral process to see specialists is really going to depend primarily upon the clinician who is making the diagnosis and managing the patient at the time. As we all know, one of the challenges with PH and PAH is a delay in diagnosis. It's sometimes difficult for a patient finally to arrive at that diagnosis in a timely way because of the fact that this is an uncommon condition and many clinicians are not attuned to it. Once that diagnosis is made, one of the responsibilities that the plan takes on is to help facilitate that access to that specialized center, whether it's a PAH treatment center or a tertiary care or academic center, wherever is going to be appropriate and most available to the member. The referral process is really something that we have streamlined tremendously over the years, and probably the biggest challenges are logistics ones. How does a patient get from point A to point B, and how do we make sure we're maximizing the efficiency of getting them to where they need to be? At this point in time, we see most patients with PAH and PH getting probably the bulk of their care from specialists. I think part of that is the fact that PAH and PH tend to be underdiagnosed. There are probably many more patients out there who have these conditions, and they're simply not recognized and not sent to the centers where they probably should be sent. I think as we see more conglomeration of the healthcare system into larger health systems across the country, that actually has obviously pluses and minuses, but certainly one of the pluses is improving the coordination and the communication between specialists and physicians in the community, whether they are local pulmonologists or internists or primary care physicians. I think that as we continue to have issues over the next few decades with manpower in healthcare, we're probably going to see an interesting shift from all of these patients seeing specialists exclusively to the specialists becoming much more of a part of a larger healthcare delivery team, which probably will mostly include, again, healthcare professionals in the community, primary care physicians, and other physician extenders who will make sure that we can maximize access for patients to this care, regardless of whether they are in the immediate catchment area of a PAH treatment center or not.